Right.
Thank you very much. My goal is to convince you that to cement a stem in a human is not a crime. My disclosures, so that's why we still do a lot of cemented stems in the endoclinic, more than 1,000 per year. First question is, does it work? There are many papers, also the historical papers by John Callaghan, who described a success rate after 30 years of 88%, or Dan Barry after 25 years of 81%. This is a patient of our hospital. She received both joints 1978, and 38 years later, she had no signs of loosening, no pain, full activity. If you are looking around the world, we have to consider that still a lot of stems are cemented, even in England and even in Australia. 50% of the stems are still cemented if you put the cemented and the hybrid together. Scandinavia, for example, is a little bit divided. Denmark and Finland is more cementless. Norway and Sweden is more cemented. Interestingly, if you look at the revision burden of a country like Sweden, where they do an 80% still cemented stem, the revision burden is just 8%. In US, for example, where they mainly do uncemented stem, revision burden is 18%. If you look at the big registries, like the NADA, 540,000 total hip replacements, cemented are going a little bit better in total. But if you look especially at dislocation and periprosthetic fractures, the cemented ones are doing much better and significantly better, especially in the early postoperative time. For whom we should use cemented stems? There's one nice paper I like to cite it always, where they talked about the uncemented paradox. That means that registry data, which represent nationwide total hip arthroplasty outcomes, suggests that cemented fixation in patients older than 75 years gives much better results. And this is proven by every registry in the world. UK, Norway, up to 74, it's almost the same, but all patients over 75 showed significantly better results and less complication with cemented stems. Even in Australia, if you look at this year, after 10 years and after 15 years, the cemented stems are doing much better than the uncemented stems. And especially if you look at here, hazard ratio, cementless versus cemented is 1.73. Sweden, also in the in the Nordic registry, where they collect all the data of all Scandinavian countries, there is a remarkable and significant better outcome in the cemented stems in old patient, older than 75 or 80 years. What about the young patients? This is a study from Exeter where they looked for the survival of after 17 years of patients less than 50 years, 100% stem survival. If you look at the Australian registry again, we find the same for the old patient, and we do not find any difference in the young patients less than 55. In the Finnish registry, where they use mainly uncemented stems, the cementless group did in very young patient did much more worse than the cemented group. What about complications with uncemented stem? There's, in my opinion, really a very high rate of overlooked intraoperative fractures. We have a quite high revision rate. This is a typical case. It's all from my cases. Patient went home very nicely. He was very satisfied. He came back after a while with this periprosthetic fracture. I'm convinced I did this intraoperatively. So if you look at the data worldwide, we must say periprosthetic fracture, especially in UK, is on the rise from 2.2% to 9.2% in 2015. Denmark, where 77% are uncemented, they have a periprosthetic fracture rate for the uncemented 2.4 and only less than 1% in cemented implants. Again, this is what we do not want. And if we go back to the Nordic registry with almost 500,000 patients, they found out that there is a 17-fold increased risk for periprosthetic fractures in women over 70 when comparing uncemented and cemented stems. And you can go all over the world. Here's a study from Matthew Abdel from the Mayo Clinic. They found 1.7% intraoperative fractures, 3% in uncemented, 0.23 in cemented stems. And postoperatively, 7.7% in uncemented and only 2%. So 10-fold higher risk. And you can go, as I mentioned, to all registries over the world, and they all show the same. The highest risk for revisions in patients is in patients over 75 years and with uncemented implants. That leads to the fact, if we are coming to the biggest registry, which is available now, with more than 820,000, almost 900 at the moment, you can see that there is a trend, a tendency in UK back from the uncemented and a little bit more to the uncemented, especially the hybrid stems. Interestingly. So they concluded in their registry in 2014 that the cemented group showed the lowest implant revision rate at 10 years in all age bands and genders. And this patient was just 30-year-old when she received it. But you need to have a very good cementing technique, as the surgeon Charlie stated 40 years ago. This is not a very modern cementing technique. This was done in our hospital by Professor Buchholz in 1976. This has nothing to do with modern cementing technique, of course. But this is 42 years ago. Today, we use mainly, and not mainly, exclusively, the modern cementing techniques with a proximal seal, use of pulsatile jet lavage and cement plug to get a very good cement penetration into the bone. So you need a dry and blooded surface. You have to preserve an exposed cancellous bone, of course. You have to use the jet lavage. Without jet lavage, you get not really a good interdigitization of the bone cement into the cancellous bone, and the depth of penetration is not as good if you just do it by a syringe. So jet lavage is a must, in my opinion. Hypotension is very important. Fight always against your anesthetist, otherwise they will not follow you. You have to be very rough to them. Because otherwise you're always fighting against the blood pressure and you cannot get this penetration of the cement into the bone. And we need probably the most important step, high local pressure. You need to pressurize. You need to pressurize if you like to cement a cup, of course, and it's the same in the stems. Otherwise, you get the risk of loosening. So if you see a radiolucent line in cemented cups in the zone 1, according to DeLee and Charnley, you have a 40 times higher risk loosening rate, as Ritter stated. Then in the stem, you have to use, of course, a distal plug and pressurizing. You need to pressurize. This is a proximal seal that you need to pressurize and to get a very good interdigitization of the bone cement into the cancellous bone put in. And this leads us, and all these facts lead us to our philosophy. In patients less than 75 years, everybody in our hospital uses cementless stems. If the older is about 75 years, then we use hybrid stems, cemented stems, and cementless cups. According to all the data, and the last registry, the NGR, with more than 900,000, they came to the conclusion that in patients over 75 years, all combinations except those with metal-on-metal bearings have good outcomes, with cemented and hybrid having the lowest failure rate. So my take-home message is use cemented stems in older patients. Thank you very much.